This program is brought to you by the Forbes-featured Freedom Hub Health Plan, the alternative to overpriced and restrictive insurance. The Freedom Hub Health Plan is exactly what you need. By Frequency Medicine Associates, supporting health professionals and laypersons with safe and effective advanced telemedicine-like technology that can scan and help rebalance the root causes of stress and illness. By the Planet Lockdown film, which can be seen on the Freedom Hub's Rumble channel along with many great speakers. And by The Pavilion, a 21st century community hub that brings together many of the disruptive innovations featured by the Freedom Hub, including direct pay healthcare, farm-to-table dining, TED-like Freedom Hub talks, and more. Visit your-mp.com/pavilion solution for details.
Go ahead, Bob. We're going to get started here in a second, but that was a story from the old days of the West Virginia Hollows.
That was the nation. We did not have in the 60s and 70s, we had doctors that came to our house. When I was 5 or 6 years old, there was a doctor that I remember him coming to bringing his black bag and taking my temperature and looking at my throat and doing all these old kinds of things. And then in the 70s, I had some people come into my office and say, you need to offer health insurance to your employees. It's a great benefit. It's tax deductible. And if they pay out of their pocket, it's not tax deductible. So, it's kind of a win-win thing. And I said, I don't like that. I think healthcare ought to be, like food, an out-of-pocket expense. You go to your doc and agree on a price and all that stuff. But that was when I was young and healthcare was simple. Now that I'm old, I'm running $100,000 procedures, and I'm no longer an advocate of out of pocket, and it's a mess. And with COVID, now we see the healthcare profession where everybody's a hospitalist following protocols and not health. And Dr. Merrick says, I'm an allopath, and all these meds for chronic stuff, including diabetes, don't work. There's healthcare by taking care of your body. So now we've got all kinds of things introduced, but we are embedded in the Medicare, Medicaid system of socialized medicine, and we have no control, and pharma has its way in Washington to get anything approved with little or no proof of its efficacy. And so those of us who have looked at this and, from BAMPA, we've got to find other ways of going, because we're not getting the benefit of health out of our system.
And that's a great intro, Bob, and thank you for that. And Jim, do you want to get things going, or do you want me, or what do you want to do?
I think I'm going to let you. I think at this point, most people know that our website is your-mp.com, where you can find our speakers. You can subscribe to both our Wednesday and Thursday podcasts. Thursday is more freedom-oriented, libertarian, and Wednesday today, of course, is health and disruption. Yeah, that was a good intro. Thank you, Bob. So Charlie, why don't you just take it from here?
Definitely. And it's something I like to do is have our regulars pick a time to present, because gosh darn it, if you're going to help us by being here to help with the Q&A, and so many of our friends and our huge list over the now 5 years, you've done this every week at Freedom Hub, are entrepreneurs and disruptors in their own right. And George Claasen is one of my favorites. And we've had lots of Rosetta type advisors, and that phrase just means to me and others, those advisors of big company benefits who do a good job. And how it's turned out, for good or better, is not using the BUCAHs, the acronym for Blue Cross, United, Cigna, Aetna, and Humana. And instead self-funding with some stop loss, and then doing something called direct contracting, which means creating an effective network for your workers in order to give them quality and also less out of pocket. And when your workers are paying less out of pocket, they no longer are what's called functionally uninsured, which becomes a barrier to them getting care. And they'll start to recapitalize from those savings with subscription plans with primary care physicians, connections with cash imaging centers, ambulatory surgical centers. A lot of innovation is happening with these so-called Rosetta advisors. George is an advisor with Mitigate Partners, and folks may recall a year ago or so, Carl Schuessler, the founder of that brokerage, presenting. He's always an entertaining presenter. From LinkedIn, I like George's phrase, today's claims are tomorrow's premiums, which kind of shows you what they do. People who are good at math and CPAs, detail-oriented, they're the ones that make good advisors for these big groups, because you have to actually dig into the claims. And if you do, you'll hear that the big spending cost drivers are surgeries for skeletal muscular problems, MSK, some cardiovascular heart disease expenses. And what's really scary, we'll get into this, is I read an article that HR departments are really worried that the third cost driver, cancer, might even overtake musculoskeletal or cardiovascular, which makes you think, why is cancer exploding now all of a sudden? And if you guys are regulars, I think you'll know why. George will be discussing reference-based pricing, which we first heard years ago from our friend Bill Hennessy at Prater, and we use that at our brokerage to find, what's a good price for this procedure to really negotiate these hospitals down from their outrageous pricing. I think a lot of folks like reference-based pricing, but on the other hand, we're trying to help these really great vendors disgorge bundled pricing in advance to allow a real free market to occur, to get that gas station dynamic with the corner cardiologist on each corner offering their price. And then, you get rid of the bill chasing, you get rid of the negotiation. It's upfront, it's bundled. We'll get to actual transparent price sensitivity. I mentioned the freeing of the capital for the businesses and DPCs and how it helps workers. One thing that too many advisors are not thinking about is the fiduciary risk. Group plans are formed under a federal law called ERISA that I dealt with when I was a congressional staffer. There's always big fights between committees over ERISA and the laws that govern individual insurance. There's a fiduciary requirement for advisors that has nailed sellers of 401ks. Not so much health benefits yet, but we had a lawyer on here a year ago or so. I'll drum up that link for that recording. Warning agents, you better stop just being an enabler of BUCAH, jacking up costs for CFOs every year, or you're going to get caged under ERISA's fiduciary requirement, and that would be a good thing. Rosetta advisors don't have anything to worry about because they cut costs 20% pretty quickly, at least. If you wonder where George's accent is from, it's not from Maine, where he lives. It's from South Africa. And Bob, at the beginning, mentioned Dr. Paul Merrick, that famous hospitalist at Norfolk General Hospital near me, who's one of the frontline doctor heroes during the COVID hysteria. And now he's on a warpath about allopathy, which he taught. He was a top teacher at medical schools. And so I like South Africans in healthcare. Everyone we've met has been an innovator extraordinaire. The question, though, is why, George, would you move from warm South Africa to cold Maine? And finally, during Q&A, we'll get into a little bit of BNI. Not only did George rise in the Business Networking International, chapters that a lot of entrepreneurs know about. He formed a lot of chapters, so we could definitely ask his advice on the merits of BNI as a platform for networking. And with that, George, take it away.
Thank you, Charlie. So to answer that question, how did I end up in the United States of America? That's a pretty common story. I was chasing a girl, and it's a girl I met in Australia, and she visited me in South Africa twice, and then it was my turn to visit her. She was working in New York. I came to New York, and then we decided, okay, we're either going to break up or we're going to take the relationship to the next level, because the long distance stuff is expensive and pretty difficult. And so we said, let's give it a shot. So we ended up getting married, family now. We moved to Boston and then up to Maine about 5 years ago. And here we are now. And I started working in employee benefits about 10, 11 years ago. It was basically when we were going to start a family, and I knew, okay, I have to grow up. I have to get like a career, because I was a photographer before. And so I talked to a couple of friends, I was either going to become a realtor, and I realized that wasn't going to be good for me, because I don't like people who are emotionally charged when they have to make decisions, and I can't listen to whining all day long. So I picked the insurance path instead. So I set off with good intentions to become an insurance person. And when the ACA came into full force, I was delivering these increases to my clients as I was building a book of business every year. And they asked me, why is everything going up? And I couldn't answer them. So I thought, okay, well, maybe I should learn more. So I try to figure out how insurance works in healthcare, health insurance, and no real answers there. And I just so happened to meet the first direct primary care doctor that opened up a practice in Massachusetts that year. It was Dr. Jeffrey Gold. So I went to see him. We had a nice long chat, and then I realized where all the problems were, and it was the healthcare system. It was, and he really opened my eyes, and he told me how it works, how it's treating the people who are the boots on the ground, getting the work done. I realized what the massive increase in administrators were, that was adding to the gluttony of cost increases. And he used a simple analogy, and he said to me, he's like, George, imagine you used your car insurance to pay for all your maintenance on your car, such as we use health insurance to pay for things that are not expensive, right? Can you imagine what your monthly premium would be? You'd basically be paying to replace your car every couple of years. So it would be astronomical. And that's what's happening to health insurance premiums right now. I mean, family plans all across America cost more than mortgages. And so most people in America buying their own insurance are paying more for a family plan than their mortgage payments are. And that's absurd. And it just keeps getting worse and worse and worse. And there's so many perverse incentives in healthcare, but my world is kind of, I try to help business individuals, but I started there, but now I'm working with larger and larger businesses as I get better and better at what I do. And I kid you not, every CEO and CFO that I meet with, when I go into their boardrooms or their offices, they all think that they have an insurance problem, and they're looking for the broker of the month to come and sell them some more insurance to fix their insurance problem. And the conversation goes something like this. I try to explain to them that they don't have an insurance problem, that it's the way that their employees are accessing healthcare and the way that they pay for that care, that is the problem. And sometimes they just blink at you and they ask you for a brochure or something. That basically means, please go away. Or occasionally, I wish it happened more than it didn't. A light bulb goes off and they're like, oh my goodness, that's the problem. What can we do about it? Now, those are the kind of clients that I like, because they act like true leaders of their organizations. They take their charge of the people under them seriously, and they want to do the best for their organization and for their people. And when you actually look at healthcare, when it comes to how does an employer give their employees good access to great healthcare, the answer definitely does not lie with getting a big insurance carrier logo on your health insurance card and giving that employee unlimited credit card and say, whatever you need. Good, there's your benefits. Good luck. Go to work. A lot goes wrong when regular people who have jobs and run businesses try to access the healthcare system because it's extremely complicated. So most people don't know how dysfunctional it is until it happens to them or a loved one, and then they're outraged. Now, we all know a lot of stories on that. Now, Charlie, you asked me to talk a little bit about the medical loss ratio. So when it comes to the big carriers, the Affordable Care Act made this law called the medical loss ratio, saying that they have to spend about 80 to 85 cents of every premium dollar collected on claims. Okay, so they get to keep the rest as profit. So, you know, they have to pay their business expenses from it, etc. And there's a lot, I mean, I can talk about this for an hour because there's a lot of other things buried in there, but just the big picture here is they get one slice of the pizza pie. Now, how do they increase their revenues? The only way they can increase their revenues is to make the whole pizza bigger. That's how their slice gets bigger. So all these contracts that these carriers have with providers, now these are mostly hospitals and you know, specialist doctors, etc. But especially on the hospital side, I call those contracts corrupt. I can prove it. And they are spending other people's money and then just asking for more money the next year. And the problem is that that's unsustainable. Now, there's a lot of businesses out there in America that's doing really, really well, but there's a lot of businesses that are struggling. And one of the problems is the cost of providing benefits to their employees, especially in an environment where there's a huge shortage of workers and companies are poaching each other's workers. So they try to do the best with the benefits. Okay. Now, I want to quickly here, just to show you guys a little bit here, hospital bills. I've got 2 hospital bills that were sent to me by surgeons that because I help independent providers as well with direct contracts with self-funded plans, because we want to save as many of independent providers as possible, because if there's none left, there's nothing else that anybody can do. And the hospitals are buying up, they bought up all the primary care practice they could get their hands on, because that's a great little referral mechanism for them for their procedures, outpatient, that really drives their revenue. And it's a lot of over testing and unnecessary testing and necessary procedures. And that's all in the name of dollars. And it causes a lot of harm too, but it also costs a lot of money. But here's a hospital bill from a local hospital. I blacked out a couple of things for this was a shoulder replacement, right? I know the surgeon who did it. The patient gave him this, and look at this. Amount before adjusted discounts, $178,000, $157.29, right? The discounts, so this is the PPO discount, you know, your carrier discount. Thank goodness for that. They knock $106,000 off the total cost, right? So the plan, which basically means the employee and the employer, was paid $71,309.88 for this shoulder replacement, right? I kid you not, this surgeon will do this same procedure for $20,000, covers every single penny. Everybody gets paid. The facility, the anesthesiologist, everybody who helped that patient. It includes radiology, the whole shebang, right? But because this employer has a BUCAH, so Blue Cross United, Cigna, Aetna, Humana contract that is paying the hospital $171,000 for a procedure that you can buy with cash pricing for $20,000, that's $50,000 that comes out of those employees' paychecks. It's a downward force on wages, so wage increases. You can look at wage increases in America. It's been pretty stagnant for the last 10 plus years, mostly because of the downward force, the cost of that, you know, of providing benefits that goes up every year. Because employers would gladly pay their employees more if they didn't give them a bigger check to an insurance carrier, right? Anyway, that's one example. Here's another one. Just to quickly show you guys this. This is on a Cigna contract. This was billed at $109,000. Oh my goodness! Thank goodness the discount was 65,000 there, so they only paid 44,727. In both these cases, the patient had a $5,000 deductible, so they were on the hook for 5,000. For these people, that's about 7 to 9% of their annual income. It's not the kind of money people have lying around, so that causes financial hardship. And this was also for a procedure that could have been done for under $20,000 with cash pricing. Now, the problem here is that the employees out there, the people who have benefits through work, they don't have any control over this. It's their leaders that do. It's the leadership team. It's their CEOs, CFOs, and they're not taking that responsibility very serious, in my opinion, in many cases, most cases in America, because there are better ways to do this, and this has been proved. There's a lot of solutions out there for all types of businesses, but the problem is they don't want to listen. Most CEOs out there don't really care about the benefits. They just say, oh, well, we give our employees, say, Blue Cross, there's your card, go to work, good luck. If you don't like it, find another job. When they could be very proactive, and they could say, well, hang on a second, we're spending millions on this. What if we could save 25% of that? Let's say we can save $1 million. What are we going to do with that money? I just helped a small group renewal, clients of mine for years. They're basically doing everything right. I kid you not, 20 lives enrolled. They have direct primary care. We're just switching to reference-based pricing now as well. But they've been level funded. And for 3 years now, the employees' payroll deductions have remained the same in the plan. It hasn't gone up. This year, it's going down. And the maximum financial exposure for an employee who works there is $1,000 per year. That's whatever happens to them, that's the most they will pay. But 90% of their care is done by primary care doctors that we pay direct to take care of them. So they have phone numbers, email addresses. They can text, call, email. The office is 2 miles down the road, 3 miles. They can go in for a same-day visit. And I think we're paying $75 per employee per month. We cover the spouses and the partners, and we cover the children too. The employer pays for that because he wants people to have easy access to good healthcare. The insurance is there for prescriptions that are expensive and anything else that happens. That insurance was designed to be there for unforeseen catastrophes, medical events, things like that, right? So not everybody embraces it. It's okay. At least we have plenty of people embracing it, and that makes a big difference on the claims. So we can see the claims come in. So 3 out of the last 4 years, they've received money back from their claims pool that wasn't spent. So that's a bonus for the employees and for the business. I'm going to show you something else quickly as well. Just moving on to the next one here. This is a client sent me this. He went to Quest for some blood work that a specialist sent him for. He didn't have insurance at the time. And he said, I'm self-pay. So Quest sent him a bill for $1,304.23. Now, if this person listened to me and signed up with a DPC doctor that I recommended, he did after this event. I sent this over to one of my DPC friends. They put the cash pricing on here for everything. I kid you not, it turned out to be a tenth of this. It was $1,300. That was the original bill. If they had direct primary care with their direct contracts for labs, it would have been $130. So they all these amounts. It's all just like these are the prices in healthcare. It's not the cost, it's the prices, and they treat regular consumers of healthcare like a bunch of second-rate citizens. They won't negotiate. They wouldn't negotiate with this guy. They said, no, we're just going to send you to collection and ruin your credit if you don't send us all that money right away. And he did. He's a financial advisor. He doesn't want anything on his record. And they do this to businesses, to individuals all day long. We all know a lot of stories like that, which brings me to the most important thing in healthcare is prices. If you're in control, so let's say all the employers in America decide tomorrow, we've had enough. We're not going to get ripped off anymore. We're going to decide how much we're going to pay for what we buy, like they do with every other thing in their line of business. You know, every piece of the supply chain has been analytically dismantled and looked upon, then put back together. Because if they can shave off 1% here and 5% there and a penny here and a penny there, that adds up to be more competitive, more profitable. There's money for growth, research and development, and to stay in business. Now, they haven't done that with benefits. They haven't done that with health insurance. There's a lot of reasons why. You can talk about that for a long time as well. But the number one thing is they kick it down to the HR department and they say, that's your department. You guys pick what's best. Okay. Now, I don't have anything against people who work in human resources. I think they have a really tough job. And I think that just to keep up with their day-to-day is a challenge on a good day. Now they're saddled with health purchasing decisions, which you need a lot of experience and certain qualifications to be able to do this well. So any organization that has somebody that has zero qualifications in this to spend $1 million or $5 million or $100 million a year is insane. You should not do that. You will not hire your teenager to run your company because you trust them. It's a matter of, can they do the job competently or not? And there's a lot at stake here. And we're not just talking about money, we're talking about lives as well. We can prevent suffering. Now, back to the prices, how do you pay fair prices for things in healthcare? That's really where my work, where I bring value to my clients. And I'll show you. So reference-based pricing is a good tool. It's not the only tool, and you can't just do that. It's one tool we use, but for whatever a provider bills us, we use the Medicare rate, and then we add, say, a certain percentage to that, and we send them payment. Most of the time, it's accepted. No pushback, nothing, because it's a business decision. The hospital know when they sue patients, they get nothing. And it could be dragged out for months and months. So we pay them a lot more than Medicare pays them in a lot of cases because we don't want the noise and we don't want the aggravation and we don't want the disruption. And it works. But even better than reference-based pricing is direct contracts. So if you can find providers in your area that take cash and they don't want to do all that paperwork to get paid, like they have to do with a carrier, and they can get audited and they can have clawbacks and they can have all these things. They can do bundles. So we pay cash for bundles and things like orthopedic surgeries. So we'd rather pay $20,000 for a shoulder replacement than $71,000 for a shoulder replacement, right? Who wouldn't? The way we incentivize the employees to help us steer them, and steerage is about quality, not just saving money. And the nice thing in healthcare is if you go where the quality ratings are the highest, the prices are usually the lowest because it's providers that do one or two things all day long and they're very good at it and they're efficient. If you go to a jack of all trades, you could end up paying a lot for everything because their costs are through the roof because there's a lot of other things going on there. But if you steer to quality, you can get better prices. And the way we incentivize the employees to play along, is we waive their cost sharing. So in a lot of the plans we build, employees can literally get all their healthcare for nothing. They have their payroll deductions for their part of the premium. The employer sets those numbers, whatever. They can turn those dials any way they like. But if an employee needs something and we get it for them, and we tell them where to go, we can remove their cost sharing. If they just want to walk into the first hospital because their cousin said it's the right thing to do, fine, do it. We're not going to tell them where they can't go, but they're going to pay a little bit more on their, say, deductible or out of pocket. So and it's a carrot and a stick, but we're not trying to beat them to death with a stick. But we want to reward good behavior because in game theory, if you have more employees who follow this, everybody wins. The whole group wins as a whole, because as Charlie said earlier, today's claims are tomorrow's premiums. So if you don't want that big renewal increase, You got to be a smarter purchaser of healthcare, and you got to go out there and find where should your people go? How should they engage in the healthcare system? When it comes to employees, that's a tough one. That's a tough nut to crack as well, because you need to do education. Most people in America are very illiterate on how the healthcare system works. And nobody's really doing much to correct this. It should really start on the employer level. The employer should decide, okay, I'm going to change the culture here. I want my employees to be wiser on how to engage in the healthcare system, and I call that a life skill. So that's a great investment. So it's a life skill. It can save your life, the life of a loved one. You can avoid mutilation. It's very important to become a savvy healthcare consumer, and there's tools. There's a lot of things you can do to help with that. I like the direct primary care route for employees who want to do the right thing, because there's nothing like that advocacy. When you're entering the healthcare system and you have a primary care doctor who knows who you are, cares about your well-being, and will advocate for you, in a system that's fragmented, that means a lot, and that's extremely valuable. But people learn fast too when they have a good, say, advisor in their corner, or a good advocate in their corner as well. Somebody who can bring all the pieces together and say, well, I think we should get a second opinion before we go with this recommendation that say this specialist did, or something like that. But there's a lot of ways, but employers don't see the value in it in most cases, so they don't give you access to the employees. So it's really hard, but there's other tools. The Quizify is a good one. I love that, where people get 10 questions a month. They can win a prize if they answer them all correct. You can do the test as many times as possible. And it's all very simple stuff that we should all know. But that way you kind of drill it into them, 120 questions a year. If they can master that, and trust me, it's not difficult. It's a big difference. It's a huge difference already right there. Another thing I want to show you guys here quickly is this is a client of mine. Sorry. So reference-based pricing, we have the reprice vendor is 6 Degrees Health. They do a fantastic job, but this is 2021 and 2022. 2021, bill charges for employees on this plan was almost $500,000. After we repriced them, all those claims, we paid out $139,000. That's $70,000 lower. In 2022 so far, they're going really good as well, but we're right on that number. $158,000 in bill charges, paid out $47,000. That's a 70% savings or discount. Not one single balance bill there. And this is not a very big group, but it's blue collar and they're hair above minimum wage. So to the employees, this means a lot. And in this particular plan, most of the employees, we have about 90-something% participation in direct primary care. We have a doctor that comes to the warehouse every 2-3 months as needed, and they'll book out appointments for the whole day they're there, or they just walk around and talk to the employees and meet new employees and ask, if they want to sign up, you can have a chat and get an appointment set up and all that. The employer pays 100% of that. If the DPC has a referral into specialty or for a test or anything, the plan covers it 100%, 100%. That's the incentive, because we trust the DPCs. They're not a hospital doctor who's funneling people into the system there. It's just a small success story, but this can be replicated all, anywhere. But it takes a will. It's the will of the leaders to say, we've had enough. What can we do about this? And then to actually take some action and do something about it. And the way I look at it is, you don't need to, everybody's worried about disruption. It's like, oh, I don't want to rip the Band-Aid off. It's like, you've got a gushing wound with 100 Band-Aids on it. We have to start somewhere. So even a small step in the right direction takes you on the path to where you need to be down the road. And we go according to crawl, walk, run, fly. Most people are out there crawling, feeling around in the dark. Once we talk to them and say, look, there's a better way, you want to get them to start walking. If they're walking and they're doing that okay and they're comfortable and they say, wow, this is great, we should have started this 5 years ago, then it's like, okay, you want to crank it up a little bit? Well, how about a little jog? And then you start, you keep improving what they're doing, adding more programs, etc. But not a bunch of junk. Like any BUCAH plan has all this stuff that nobody even cares about or uses. By the way, they can write that off as on MLR as healthcare. So they make themselves rich and produce absolutely very, very little value to the majority of the members. And then and just always keep in mind that an insurance carrier, like the big ones out there, their CEOs, there's a lot of news about what they get paid, but they're worth every penny that they get paid, because their fiduciary duty is towards their shareholders and their investors, not their plan members, not the people paying premiums every month. That is not where their fiduciary duty lies. So when they increase premiums and their share of the pizza pie gets bigger and bigger every year, they're doing a great job and they deserve those big salaries. Make no mistake, in a capitalist system, they do. I'm not saying it's right or it's wrong, but that's how it works. And if people think regulation is going to fix this, anybody can give me an example where the government interfered with healthcare and it made it better, because I can't really find those examples. And when it comes to our world, where we are innovative, it's a matter of time before some politician starts tinkering with it, and it's usually on the behest of somebody in the BUCAHs. Say, for example, the individual tax mandate, right? There's still 5 states doing it in the country. Now, why would you tax people who don't want to pay an insurance for an insurance plan, right? It's my opinion on that is because Blue Cross will complain, or whoever, any other big carriers or all of them would say, well, hang on a second. They're taking healthy people out of the claims pool, so that's going to just drive prices up for everybody else, okay? But then the way I look at it is, well, why should everybody be discriminated against in the same way? Why can't people have more choices? Why can't people say, well, I don't like your cookie cutter solution. I have a better solution. We're doing something else and it's working and we want to stick to it. Why should they be meddling? And then another thing with healthcare reform that I have a big problem with is it's a great way to buy votes. So since the ACA started, every time the government throws another regulation in there, they create 1 million jobs, right? All these factory jobs that disappeared that in the early 2000s, that was a big problem. And people were, what are we going to do about this? This is a serious problem for the country. And then when the ACA came around, it's like, bingo, we fixed that problem, because now all these people are administrators. Easy to train them. It's a solid paycheck. They spend a lot of money in the economy. And then how do you keep that thing going? And the answer for that is just keep regulating it more and more and more. And then you create more and more and more jobs. And the way this is trending, and this is just my opinion, is United Healthcare is setting themselves up to be the biggest government contractor in the history of the world. And they're close. We're very likely going to see a huge growth in Medicare Advantage. And eventually it's probably going to be like, oh yeah, sorry, it's all private contractors now, but the government calls all the shots. They write the checks. It's just interesting what's going to happen to the doctors. Like in Canada, can they work for themselves or not? I don't think our constitution would ever allow that, because it would be un-American to tell somebody you have to work for the government now, just out of the blue. Because it doesn't matter whoever writes that check, that's who you work for, period. You can have another name on your W-2, but with that money's coming from the government, you're a government employee. And if they would decide to pay you less next year and less the next year, that's exactly what they'll do. And this is what we're seeing in Medicare. And then lastly, I'll just wrap it up. There's been studies done all over the world about how to have a healthy population. And there's one thing these studies have in common, and that's if you want a healthy population, you have to give the people easy access to good primary care, period. They don't disagree on that. In America, we're spending 2 or 3 cents on primary care out of every dollar collected in premium, right? And our primary care doctors, we don't have enough of them. And because of the insurance system, they sacrifice the doctor-patient relationship for coding and billing. So when you speak to say primary care doctors, they're spending half their day, if they work in the fee-for-service system, they spend half their day doing admin work, and a lot of that they have to do at home when they're not at work, just to get it done so they can go to work again the next day. They don't get paid to follow up with a patient. If somebody walks in there and they say, okay, look, I've got just a couple of minutes, how are you? And they try to figure out what prescriptions to write, what tests to send them for, and what specialists to refer them to. And that's a tragedy, because when we see the difference in care, when it comes to people who have an actual direct primary care relationship, say DPC, a doctor they know that knows them, and they've been with them for a couple of years, and you know, when they need to, you know, it's like that's how you practice health care. You know, the word health is important, but our healthcare system is a sick care system, because all the money is in sick care. So that's why primary care, they don't see it as important, because it's keeping it, if it's done right, it's supposed to keep people healthy and out of the hospitals, right? But there's no money in that. So why don't we just buy all the primary care practices and use them to steer people into our hospitals? And when you look at the non-compete lawsuits across the country, so the hospitals all cry and they say, oh my goodness, we lose money on buying primary care practices. We are the good guys in the community. We're keeping them in business, and so that they can serve the communities. But when they leave and they do their own thing, they sue them for between $1.5 to $2.5 to $4.5 million of lost revenue for 1 year, because that was the steerage that they were pumping into the hospital system, right? So the truth comes out in court, and you can find these documents online, and there's a lot of articles written about it as well. But that's the problem. We have to decide: do you want to be part of a healthcare system, or do you want to be part of a sick care system? And then if you're the leader of an organization, that's a choice that you have to make, and there's a lot at stake there. And if you can make that choice and act like a leader and pull it through, you need to find a good advisor that knows how this stuff works, and that's mission driven, that can say, okay, it's a rigged game. We're gonna, we can do something about it, but everybody's got to be on board, and you've got to have buy-in right from the top. And if HR complains about it, you just got to say, look, this is a leadership decision. This is what we're doing. So let everybody start pulling for the team here. And if they don't want to do anything about it, they just budget in. Okay, we're going to have 15 to 25% increases every year, year over year. And we'll just, pay our employees less and charge our clients more, and hope it works out. And that's it in a nutshell, guys.
George, that was fantastic. And we have a number of questions. Before we go there, if you have real small businesses that may not be ready to self-fund, or individual friends, where do you refer them to with open enrollment coming up? What's the best way for them to protect against unforeseen catastrophic expense?
For individuals,
or small groups, that don't want to self-fund.
Yeah. You know what? I would still say talk to a good advisor regardless. I've helped businesses with 2 employees self-fund, like level fund, but it's better than being on a BUCAH plan, because we know what those rates are. Now on a BUCAH plan, right? If you're a small group, your merge market, they're rating you as the sickest in the community. So if you're a group that doesn't deserve that rating, and you're willing to do, say, health questionnaires, then the underwriters can say, oh my goodness, this is a great group to underwrite. There's not a lot of risk here. We're going to give them a really good premium. And that's a big win there for a small business. It's like, oh, people, they can tell their people, we have a better plan now. We're not subject to the rules of your regular BUCAH carrier. We can add direct primary care. There's a lot of things that small groups can add that the big groups add. And all of a sudden, employees become more savvy consumers of healthcare, and they get it. It's like a light bulb that goes off. And after that, the renewals, they don't go back. They never go back. Sometimes they might have a terrible year in claims and they have to go back, but there is a safety net for the merge market that always grab them. But if you don't need to be there, don't be there. But if you talk to a regular, these big agencies out there, they're brokers. Let's talk about that for a second, because that's part of the problem, right? If, let's say you're a broker at a big insurance company, one of those alphabet houses, right? Now you bust your back for 5 or 10 years and you build up a book of business, right? You go and hustle and you get the clients and everything. Maybe 1 year you want to move a client because they're getting a big renewal with one carrier to another carrier, right? Nobody tells you this because you didn't get the memo, because there is no memo about the bonuses, you know, the retention bonuses. So the agency as a whole, if they lose a certain percentage of business from one carrier, they lose that whole carrier's retention bonus for the whole agency. That's millions and millions of dollars, right? Depending on the size of the agency. So all of a sudden the broker's like, somebody comes and grabs them by the ear and says, hey, come into my office. It's like, yeah, we're not moving that client to that carrier because this will happen, right? So they can't be honest to the clients they're supposed to serve. They're not really working for them, because what happens if that broker gets fired or quits? He's out on the street with no income. He's got a 2-year non-compete that he can't get his clients and come with him. And so they all just play the game. They're like, well, I'm not gonna, if I lose this client, my job, my wife's gonna divorce me, my kids are gonna be miserable. It's like, I'll just keep my head down and I'll play the status quo game here. You know,
what about sharing for small groups and individuals?
I love it.
Insurance.
I love it. You know, like that's one of my go-to solutions for many of my groups. I've got a hotel group with over 100 employees doing that with direct primary care with the ICRA. So then people who need insurance can buy a plan on the exchange. The employer saves so much money that their contributions to the people who go with the ICRA is extremely generous. It's costing them so much less than they had an Anthem plan, this particular client, which had 25% increases year after year. And then they said, no, we're done with that. And that's, you know, that they met me and we went to work, and then that's working well. So if you have, a population, so direct primary care is your front line. This is my population health, #1 go-to tool. And you encourage people to embrace it. And then you have the health sharing as a finance mechanism for things that you can't predict. So the amount of money that frees up for small and large businesses is fantastic. For individuals, like personally, here's the thing. Nobody ever asks the insurance guy, what do you do for your family? Nobody asks me that. They should. So I just tell them, you know, I'm on a health share for my family. We pay $450 a month. Our financial exposure is $2,500 for a need. So if somebody gets injured or hurt or sick, we pay the first $2,500, and we've been there and we've used it, and it was great. It was seamless. We just said self-pay, and I'm talking. Okay, let's go. Physical therapy, chiropractor, X-ray, MRI, CAT scan, ultrasound, hospital, day in the hospital, all of this stuff, all for one thing, right? And over time, spread out over time. Everything, hospital, everything, we're like, oh, we're self-pay. Can you just bill us? Yeah, no problem. Bill comes in the mail, send it to the health sharing organization. They negotiate it, or they just send us the money to pay it. We had to pay the first $2,500. Not rocket science and nothing to be scared of, and it worked for us, right? So I pay $450 a month for my sharing. Then I have direct primary care, right? So it's like, I think that's around $200 for the family. Deal of the century right there. We actually get value from that because that's healthcare, not sick care, right? So my doctor's actually on here. I see Jeffrey Gold right there. How you doing, Jeff? So far we're up to what, $650 a month, right? And then I put money in a health matching account. So, because here's the thing about my health matching, right? I worked out a family dental plan is going to cost me $174 a month. A vision plan is going to cost me $20 a month for the family. So I'm like, well, I'll just stick $200 a month in my health matching account. It's up to $7,000 and change, and we've used thousands of dollars out of it. And in another year from now, it's going to be almost up to $15,000 just of money I can spend in healthcare. I mean, and for all this, I'm paying $450, $650, $850. So under $1,000 for my family. See, I'm the insurance guy, and people ask me, why don't you have health insurance? And I'm like, well, because it's a scam. It's if I go to the exchange and I buy an Anthem plan, and all of a sudden Now I'm sending money to a carrier and the premium is more than my mortgage. And then if somebody gets sick, I have to write a check for $15,000 because that's the maximum out of pocket. And that's where all the expensive stuff has co-insurance on it. So, hey, spend a day in the hospital, you're writing a $15,000 check if it's, maybe a little surgery involved or, some tests and all this. It's a complete scam and a complete rip. I showed you guys those hospital prices, right? And how the carriers generously reimburse them. And I'm like, no. It doesn't have to be like that. So when people, want to know, like, what is the guy that supposedly knows everything does? That's what I do. And it works really well for me. And I have a lot of clients because I started in the individual and small business space. I'm a small business. And I'm like, I still help those people. So with whatever the solution is. And the only problem is not everybody listens to good advice because they're so brainwashed. In America, I talked about that literacy thing. Most people in America think health insurance is healthcare. They think it's the same thing. It's not true. It couldn't be further from the truth. And that's really where it all breaks down right after that. People think you can't get access to healthcare if you don't have insurance. It's complete nonsense.
George, we're running out of time. We have lots of questions. I'll just note that the sharing recommendation you made with health matching accounts and DPC or HSA, that's what we sell. I sell. That's the sponsor of this program. So folks, for open enrollment, you know how to reach me. Dr. Gold, why don't you add to that with the DPC parts of health reform real quick, and note that you'll be on here next week for a longer presentation.
Yeah, I mean, just to echo George's sentiment, I mean, George is like a pro here, explaining all this stuff. But I think the hard part is how do you put a numeric value on a relationship? And it's, something that we know employers want to see, their ROI, of investing in, a DPC type primary care relationship. But the reality is you can't build a mansion on a foundation of sticks and twigs. And that's kind of what we've done with our system in general. Primary care, as George mentioned, has been really devalued to the point that, people don't even see the purpose of it because of what they've been exposed to. And, we're really trying to change that from the bottom up. The top-down fix really hasn't worked for decades. And I think, as George mentioned, the best thing to do, in my opinion, whether you're a benefits advisor, a policymaker, patient, is walk the walk and talk the talk. And I mean, me and my children are on Sedera. I'm not going to support, an insurance company that charges me $500 a month more. I try to do all the things that I preach. I think it goes a much longer way, trying to get employers and patients on board. But, I think he touched on all the high points, but I think, the real value we add, other than access and care and all that stuff, is really helping people navigate, this labyrinth of a system that's built this way on purpose. People always say the healthcare system's broken. I'm like, it's not broken. It's built exactly the way it was intended to be built. It's just the people that it's broken for, the two people that matter most, the patients and the doctors. Without us, there is no system. So, as George mentioned, it's up to, it's sadly up to us. It's up to patients, it's up to people, it's up to doctors to really make the change. No one's going to do it for us. But I think if we do that and invest the time and energy now and take baby steps, we'll actually, build something for our kids and our grandkids that actually functions the way it should, without making them go broke by doing so.
Thanks, Dr. Gold. And folks, mark your calendars for next Wednesday at noon when Dr. Gold will give a fuller presentation on DPC. It's probably the most important linchpin for reform, to get that capitated payment, which gives the patients and workers that time that they need with their primary care healer to keep them healthy. Bob, you've had your hand up for a long time, and then Michael, go ahead. Unmute yourself, Bob.
Dr. Gold, can you hear me?
Yes.
Okay. As a DPC, COVID comes along, your patients come to you. What did you do? How did you?
Very simple. My job. I took care of them. If we needed to see somebody in person, whether it was for a COVID issue or non-COVID issue, like stitches or something, we took appropriate measures and masked and took care of them. And, if we could do something through telehealth, we did it through telehealth. I mean, we really, didn't have to do much of anything to change our business model. I mean, really the only thing we did differently was some of the routine, well child checks and routine checkups, we pushed out a bit, to deal with the more urgent pressing stuff. I mean, even if you wanted to get somebody a colonoscopy, if they were due at that point, it was pretty tough to do so when the specialists were all closed and not seeing patients in person. So, we really, I don't know. It's, we treated people the way that, I felt was in their best interest, not being part of the system or what I call the cartel. I tried to practice medicine the right way, what I thought was mostly beneficial with the lowest risk possible. We try to treat people as individuals. I mean, not everybody, you could have two 45-year-old white guys standing next to each other, but they could be totally different with what their social needs are, what their medical needs are, what their risk profile is. So, I tried to do what I can within the limits of not losing my license. I'll just leave it at that.
Well, what I meant, my primary care was part of a system, and it was an employee. And she said, if you get COVID, you wait till you're really bad and go to the hospital. And then that protocol was going to be what's the remdesivir and ventilator. Yep. And high percentage of death. And so my question to you was related to COVID. Were you able to keep your patients out of the hospital through other means? I know the ivermectin and hydroxychloroquine was, in some cases, medical death or practitioner license risk and all that. But were you able to keep your patients out of the hospital?
Yeah, I mean, I don't have data to, support it. It's all anecdotal, but I can tell you from having a smaller panel size, I only had one patient that I can think of that ended up admitted to the hospital. And it was, he was actually the first diagnosed patient in our county that was at the Biogen conference in Boston. So I think that, it was pretty early on, and I don't think really anybody really knew much about anything. But other than that, I really didn't have anybody that ended up admitted to the hospital, or I think I had one patient with bad asthma that ended up failing, inhaled steroids and some of the other things we tried, and ended up in the ER and got admitted. But, it's and just a comment. I don't know Charles here, but I'm reading his comments here on the my license being worth more than your life. I would say that's not really the case, but unfortunately I have to be able to do my job, and in order to do so I have to have a license to practice. So I always try to do the best I can first and foremost for my patients. But as we all know, there's, I don't like paying taxes either, but I have to do that as well. So anyway, I hope that answers your question more
Yeah,
specifically.
it does very well. I wish I'd had you for primary care rather than mine.
Where are you located?
Williamsburg, Virginia.
Well, I am happy to try to find somebody down there. I know a lot of good colleagues of mine. I'm pretty involved nationally, and we're slowly building the army across the country. I think you can drive from Maine to Washington now, or even Alaska, I think, and go through a state that has a DPC doc. I think South Dakota is the only one that doesn't have a current independent DPC doc, but I'm happy to try to help you find somebody, and can certainly give that info to Charles and have him pass it on to you.
Well, Charles and I have been talking, and I have come from real estate development background. I had a 130,000 square foot busted retail facility that I redeveloped as office condos. And I had, and this was probably 14 years ago. I was selling to individual docs. And whenever you plan an office and sell space direct and everything like that, and then building it, you get right in there. You're like a doctor for these people, because you want to help them, get what they want. Uniformly, the little docs that I was working with were what was stated earlier. Their biggest problem was billing, administration. It was killing them.
Yep.
I've sat with docs that were in tears. They were upside down. And in one of the spaces that I sold, there was a guy doing medical billing, and he's grown into from 3 people, in the last 12 years into a substantial practice. This is third-party billing, which has a cost, and the medical system has to pay. So it's tremendously inefficient as opposed to and this is just to get the billing out. This is an administrative cost to, get the money in. But I also worked. The hospital bought some space from me, and I ended up becoming close to their leadership. They wanted to do a sports medicine facility inside this building. And I went through all kinds of meetings. And in those meetings, they were showing me, their cost structure. And uniformly on their billing was, here's $1, but we can only put 63 cents to the cost recovery of the facility. And that was built into their pricing. That was never fully explained to me. But I started off pre-Obamacare. And as Obamacare came on, there was a really smart vice president, very financially oriented, and he was in charge of the acquisitions of doctors. And he said that they were getting paid at the hospital level 30% more for a same procedure that my little individual docs were doing. And so they were buying them. It was a no-brainer. And when I talked to them about partnering to do an ASU in the building, they said, we can't get our boost, our 30% boost, because it's too far away from our hospital. So these are some other problems. And I was also a 50-year employer with healthcare for employees from 80s on. And it was all, I was like the stupid HR person. I had an insurance agent. Nobody was coming up with anything, and they were just brokers. But the prices that I saw after Obamacare were, $5,000-$6,000 deductible and maybe $24,000 a year premiums. I said, holy cow, how can anybody afford to be an employer? So fortunately, I'm retired, but I never solved that. Now I'm, doing $100,000 cost on Medicare, and with $6,000 deductibles that I'm hitting, and I'm not getting health care. I'm getting sick care, and so that's why I find you all very fascinating. You all are still in the game.
Thanks, Bob. And we're kind of out of time. Michael, if you want to sneak in a quick question, we'll wrap it up.
Yeah, absolutely. George, just a quick question for you. For some of us that kind of work in like healthcare public policy advocacy, advocating for like a more consumer-oriented system, what are better ways that we could be able to talk about the work that you guys are doing to kind of show that solutions are working in healthcare?
Yeah, no, I'll take a stab at it, but I don't really know much about your world, but it seems to me anything with politics is like swimming in a sewer. And I think there's a lot of useless people in that space giving advice and getting paid as consultants that are really working for somebody else. And there's a lot of people that are planted. I find that if we really wanted to make vast improvements in America, we could do it quickly, but there's too many special interests. There's too much money at stake. You're not going to change a $4 trillion, soon to be a $5 trillion system because it's the right thing to do. And then a lot of these, when I look at a lot of initiatives and think tanks and this and that, they all fall short somewhere in more than one form. And it kind of makes somebody like me wonder, do they have alternate motive, or what's really going on here? Does common sense and reason and logic not prevail? And I'm just like, and then I have friends who work in policy and who in the stuff they tell me, it's like, I'm like, a lot of hard work gets undone when it's time to make a change. And I'm surprised that people don't just give up and walk away, but they still go back to the slog. So I don't know, but I would just say, if you really want to fix a problem, talk to people who have fixed the problem. The theory is one thing, and there's a lot of people who live in that world of theory, but they can't run an ice cream shop in the real world. And they're the ones who have such a big sway on what policies get changed or don't get changed or get implemented.
And George, why don't you close with a comment, a takeaway, and how folks can reach you?
Yeah, sure. I'll say that to solve this problem is not that hard. And I think one thing that's vastly lacking in the world today is personal responsibility. A lot of people throw their hands up and say, it's not my fault, it's the system, or there's nothing I can do about it. But that's definitely not true, even for individuals. There's a lot that they can do about it. And you should start by learning and educating yourself. And that once you start doing that, it's easier to pick the right paths, the better paths for you. And as I said earlier, that's a life skill. We all need that life skill. They don't teach it in schools. There's a lot of things they don't teach in schools. So if we're going to say, well, I don't, it's like, no, Amazon, everybody has Amazon Prime, get an Audible, get a book. There's a lot of good literature out there. Put your name on some newsletters, start to see what's going on. I subscribe to so many different things, good, bad, this and that, but I want to see what the other side is up to. I want to see what the latest buzz is and this and that, even though to me, sometimes that's comedy hour to read that stuff. It's absolutely friggin' hilarious. And it's never going to go anywhere and never solve anybody's problem. But yeah, personal responsibility, I think, is number one. And the other thing is leadership. This country was built on great leadership, and we've kind of lost track of that for wokeness. Replace it with wokeness instead. I'm like, hang on a second. true leadership is something that can make big differences as well. And if you're the leader of your family or organization, it's your responsibility. Take it serious, roll your sleeves up, and don't be afraid to ask for some help. There's nothing wrong with that. The reason we don't live in caves anymore is because of our combined knowledge that we share with each other. That's why we don't bang rocks together to make fire every day now. So ask for help. Ask somebody else who's done something. And I think easy way to get in touch with me is just find me on LinkedIn or Google me. I have a website called DPC Friendly Broker. I hate the word broker because brokers make you broker, but it's a phrase that people use. So if you want to bring DPC to your business and learn about other things, just Google DPC Friendly Broker. You'll find me there. There's a picture of Dr. Gold there too. but it's a good place to start. Just say, this is the last day that I'm going to feel around in the dark. I'm going to get a match and then a candle and then a flashlight, and then I'm going to turn the lights on, and then I'm going to shine a spotlight on it. It's that Leonard Cohen song, there's a crack in everything. That's how the light gets in. We need to let the light in. Especially, we need to pull the curtains back, and we have to shine light on how this whole thing is really affecting us, because there's a lot of things. I mean, a very good reason is, and I'm not even talking about COVID now, but we kill about 250,000 people in America from preventable medical mistakes. Now, the word here is preventable. If this happened in aviation, the FAA would shut down the air completely until they figure out why is this happening and what can we do about it. But in healthcare, with the incentives as they are, if somebody gets an infection and they're fighting for their life in the ICU, the hospital makes another $1 million. Come on, it's absolutely ridiculous. There's no accountability, but it's a long journey. It's going to take a lot to fix it, and we can't sit around and wait for it to be fixed. We all have to do it for ourselves in one form or another, and it affects our communities. And if you can help people in your community to start to go on this road as well, I think for a lot of people things can get better and not worse.